Hi, I'm Paul Rosenberg. I'm the Richmond Family Professor of Alzheimer's disease and related disorders, the director of the Division of Geriatric Psychiatry and Neuropsychiatry in the Department of Psychiatry and Behavioral Sciences at Johns Hopkins University School of Medicine. I want to talk about one of my favorite topics ever, lifestyle strategies for prevention of cognitive functional decline. Disclosures, don't want to go through the details, but I do a lot of work on clinical trials, and most of my disclosures are consulting to industry, either on clinical trial design or analyzing clinical trials results. I'll be discussing off-label use of a few drugs, methylphenidate, dronabinol, and citalopram. I'm not sure if we're going to have those. Um, They're my objectives. Bottom line, it's an exciting time in Alzheimer's disease. We have new diagnostic tests, including plasma biomarkers, and we have new disease-modifying treatments, which include monoclonal antibodies. But these new medications have modest or mild effects at the best. There's growing evidence base suggesting a protective effect of lifestyle strategies. The epidemiology is very persuasive. There's tons of data on a lot of the things I'm talking about today. The clinical trials evidence has been sparse and some questions about the effect size. Is it large enough to make a difference? The other bottom line is there's a lot to suggest that you've got to make the lifestyle changes in midlife in order to reduce the incidence of late life decline in dementia. There's a recent Lancet review suggesting that greater than 40% of Alzheimer's risk is due to modifiable risk factors. And I will be addressing most of these, maybe missed one or two today, for the interest of time. Exercise, depression, vascular risk factors, hearing and vision, social engagement, smoking, ethanol and air pollution. And that's been replicated in US cohorts. And as I said, it's actually midlife cardiac risk factors that are most influential in late life dementia. This is this is a graphic I borrowed from the Lancet article. And my main point is um, education in early life may be protective against dementia. And then midlife is where most of the risk factors come in, mentioning hearing loss, cholesterol, depression, traumatic brain injury, and so forth. There are not so many late life risk factors with evidence, and in some ways, I think that by the time you get to late life, it's you the harm, the damage is already done. We may not be able to affect it that much, but social isolation and air pollution particularly jump out. A lot of busy slide on potential mechanisms. But if you look at the middle, the hope is that the hope and the thought is that these lifestyle strategies may decrease vascular damage. They may directly affect dementia neuropathology. They certainly may affect and reduce stress and inflammation. They may help people build cognitive and brain reserve. And these are all potential mechanisms for prevention. Here's the agenda. I'm not going to read it to you again, but there's a couple things I just don't have time to cover that I think are interesting. Air pollution and spirituality. Vascular risk factors. Midlife vascular risk factors are associated with late life cognitive functional decline. These include obesity, or elevated BMI, hypertension, and lipid profile. It suggests you got to intervene early. Sprint Mind. Sprint was a study it's comparing aggressive blood pressure control under 120 over 80 versus usual care. And aggressive blood pressure control was associated also with decreased incidence of mild cognitive impairment and cognitive impairment in general. Dementia incidence was at a trend level, so everything went in a positive direction. There's some imaging evidence it's associated with increased cerebral blood flow. However, there are also, including in terms of other clinical trials, there are a number of other studies that showed no improvement on using tight blood pressure control. And just here's a pretty picture showing you that the y-axis is the incidence of cognitive impairment, and the x-axis is years. And over 7 years, you can see that about 12% of people on usual care got cognitive impairment, and only 6 or 7% on intensive treatment. It's pretty dramatic and statistically significant difference. Aerobic exercise is associated with lower risk of dementia in a lot of epidemiologic studies, also with increased hippocampal volume. The mechanism may be improved vascular function, but it also may be reduction of neuroinflammation. The trial's results, though, are a bit mixed. That's why we have to sort of caution your optimism here. Here's the biggest, best trial so far, in my opinion. Exert, done by our close friend Laura Baker at Wake Forest. She did a randomized controlled trial of aerobic exercise versus stretching bending resistance in almost 300 older adults over 12 months. The most remarkable thing about this trial was that she completed it through COVID. And even in the middle of COVID, many of the participants really wanted to go to the gym and be part of the trial. The exercise was supervised by YMCA trainers. They saw no hit on their favored cognitive area, which was executive function. Um, but both groups declined more slowly than historical controls. There was no difference between the groups, though, in cognition. It suggests that both aerobic exercise and stretching bending resistance might be good for your brain. Well, how many steps do I need, Doc? I practiced my whole life in the United States, so when I talk about exercise, of course, people say, "What's the minimum? What's the minimum I got to do here?" It's from the Harvard and Brain and Aging study, followed almost 300 adults for up to 10 years, counted steps the old way with a pedometer. Step count was not associated with amyloid, interestingly enough, but steps protected the participants from the deleterious effects of amyloid. In other words, if you're amyloid positive, and you exercise, you had some protection of your cognition and less tau burden in your brain. Also, the number was more like 3,000 to 7,500 steps daily if you look in the graph at the bottom right. Doesn't have to be 10,000. So number one, this supports the benefits of getting off the couch and taking a walk. The second thing is you should know this thing about 10,000 steps was not based on any science. It was it was an advertising effort by a Korean company to sell Fitbits. And I mentioned potential protective mechanisms, including neurotrophic factors, improved blood flow to the default network in the brain, improved postural control and cerebellar integration. And there's some evidence that combining aerobic and resistance training has synergistic effects. All right, let's go on a diet. It's the hardest thing for people to change. Mediterranean diet, you've all heard of. It's focused on reducing saturated fat intake. It's known to reduce cardiac mortality, and there are potential benefits for reducing dementia risk. I like to call the MIND diet the Mediterranean diet plus a lot of berries. It's really quite similar. It's based on the MIND diet, and then they add what they believe are antioxidants, including berries and green leafy vegetables rich in vitamins and antioxidants. It's a mashup of the Mediterranean diet and a low salt antihypertensive diet called DASH. There are several clinical trials suggesting a reduced risk of dementia. Here is a meta-analysis of forest plot, and if you look at the bottom of the right-hand column, you will see that the MIND diet studies, if you bring them up in total, had a protective effect, a reduced incidence of dementia about 17%. That's as good as any of the antibodies. I mean, it's a different target, but it's a substantial effect, and I recommend this to all my patients. Potential mechanisms, the most important thing, and it's a little similar to exercise, the most common pathology in dementia is not pure Alzheimer's, it's mixed Alzheimer's and vascular disease. The reason we're not sure about how many is that our biomarkers for vascular disease are not very good. The Mediterranean diet targets lipids and atherosclerosis, really may work just like cardiac protection, also may target neuroinflammation and oxidative stress. But the important link that we really wish we knew the answer to is dose. Is there enough antioxidant, for example, in the MIND diet to make a difference? Resveratrol. You might have heard of resveratrol. It's a anti-inflammatory agent, and it's found in red wine, and you can also buy it over the counter. And the question is, what's the dose? And it turns out if you want enough resveratrol to really have an anti-inflammatory effect, you need to drink several bottles a day. I've heard there are other side effects associated with that. It's a joke, but um, it's not a practical solution. So people who want to try resveratrol need to take it as a supplement and not just drink red wine. And just a pretty picture about what's in the Mind diet. And I think you'll see it's a lot like the Mediterranean diet with some green salad and some berries added. So it's certainly good for cardiac. It's probably good for the brain. Brain training. Well, I like to think of brain training like the concept of happy adolescence. It's a great idea if it actually works. Um, it's not clear what works. There's been a huge amount of it's like a cottage industry of lots and lots of companies are trying to sell you their products. I don't own stock, I promise you, but there are two companies I'm fairly fond of. Lumosity, because they share results with researchers. Brain HQ has some promising results, but I'm not making any claims that these really, really work. I also like these two because they're not terribly expensive. This also fits in with the idea of education being protective. Although the education that's protective needs to be early in life. Getting a PhD in your 70s probably doesn't protect you against dementia. Depression, there's a ton of studies showing an association of late life depression and dementia. The actual kind of drug epidemiology studies are all over the place. There's like one study suggesting SSRIs are protective against decline in people who have MCI and depression. No prevention trials to date. It's a hard area to do studies in. Here's a forest plot, a meta-analysis showing that there's a higher dementia risk in people with late life depression, more than doubles the risk, 2.39. So it has a ratio of 2.39. So pretty impressive. I've done a psychotherapy study. Can we treat depression with psychotherapy and improve cognition? Working with Dr. Kiosis, who is a brilliant guy at Cornell Westchester, and he's basically been developing CBT variants for many years, including cute acronyms. His acronym here is problem adaptation therapy, and there's more of an emphasis on adapting to challenges rather than identifying cognitive distortions. It's a little bit of a different theory than CBT, although the practice is not that different. And he's adapted it to MCI. Interestingly enough, it basically combines regular CBT with some kind of practical case manager type interventions, including helping people use mnemonics, lists, etc. So this was a randomized control of his PATH MCI versus a supportive psychotherapy. They both had manuals, 24 sessions over 6 months in persons with MCI and depression. I didn't put the number, but it was actually 80 patients. So it's a pretty substantial study. It didn't do anything. It did improve mood, but it did not improve cognition. So it's a disappointment. But it's just one approach to treating depression. More social engagement and leisure activities may be protective, fairly challenging to study. But if you look on this forest plot, just look at the top few lines, which are about social engagement. And what you can see is that having less social engagement increases risk of dementia, less social contact, and in some studies, loneliness. Loneliness is getting studied more and more because people's perceptions of loneliness is often not really linearly connected with how many people they see a day. It's more of a concept than just pure network theory. Here's an interesting trial. iConnect, Hiroko Dodge at Oregon State is the PI. What they did was cognitively stimulating conversation over Zoom. They did it over a year with 186 participants. I don't have the number. I think it was 3 times a week. I think it was research assistants doing it. They improved cognition in the intervention group, 1.75 points on MoCA. It's not a huge effect, but it's impressive to see any. If you look on the right, you'll see some improvement in the MoCA, not so much on the memory test, which was called Craft Story. Sorry, she did see a similar benefit in the Kraft story, but it was more equivocal. Um, and she saw increased functional connectivity in the dorsal attention network. So that's just an example, one approach. And I can tell you, this is not psychotherapy. These are young people, research assistants calling older persons and having a slightly structured conversation over Zoom. It can be done by anybody. Hearing is a great target. Hearing loss is associated with incident MCI and dementia. The amazing Frank Lynn, who's an ENT doctor at Hopkins, he's a huge advocate for hearing aids, and he's been quite instrumental, for instance, in persuading the FDA to open things up so there are now over-the-counter hearing aids. And Frank is actually, at least in recent years, was consulting to Apple to turn earbuds into hearing aids. So he did a controlled trial I'm going to get to in a moment. And then another Hopkinsite, who's now at Colorado, Yuri Agrawal, has found vestibular dysfunction. I did not know there was such a thing as vestibular therapy, but she's been doing it. I don't know the results yet, but she's doing the vestibular therapy to see if it improves cognition. Um, and here's an epidemiologic study. Look at the left. What you can see is you got four graphs over 15 years or so, normal hearing down to severe hearing. And what you can see is the people with severe hearing loss. And what you can see is the people with severe hearing loss had a much higher chance of getting dementia. It was actually the hazard ratio was almost 5. So hearing loss is certainly associated with incident dementia. And so here are some methods that Frank proposes as potential mechanisms for the how hearing loss might contribute to dementia. There's increased cognitive load because you got to concentrate more to hear what's going on. There may be effects on brain structure and function, and people who are hard of hearing are probably feeling more socially isolated. And so the hope is that if you wore hearing aids or some other device, you might reduce the cognitive load, you might increase brain stimulation, you might be able to improve social engagement. And here is a meta-analysis showing that hearing aid use was associated with a lower with better cognition. This one, it was associated with less cognitive decline, 19% less. It's quite a bit. And just to summarize his study, he did a study of people who were cognitively normal, and I think they had needed hearing devices. And what he found was no effect in the whole cohort, but he had two cohorts. One of them, healthy self-referred volunteers, no effect. The upper one, which is called ARIC, is a study where very much enriched for vascular risk factors. And so we had a sense that hearing aids were helpful for cognition in people who had significant vascular risk factors. So an example where we might be personalizing medicine. Sleep, our favorite time of day. Amyloid is probably cleared during sleep. Amyloid probably makes sleep worse. So there can be a bidirectional relationship where poor sleep and amyloid deposition positively feed back on each other. Amyloid also leads to abnormal circadian rhythms. We've been doing a number of studies in this area. I just show one example comparing amyloid positive versus amyloid negative cognitively normal people. And the amyloid positive had a these are log it's log, so it's not as impressive as if we just shown you straight numbers. But the amyloid positive group had a different circadian rhythms at different times of day. And we're actually doing a study of trazodone, trying to treat sleep and cognition in mild cognitive impairment. That's just a description of it. Vitamin studies, there's so much. I don't have time to really review it in one slide. There is some evidence for benefit of polyphenols. I mentioned resveratrol. Certain B vitamins, folate probably has the best track record. Vitamin D and beta carotene, vitamin A. We're interested in dietary changes because they tend to last longer than taking supplements. And so we recommend green leafy vegetables with many B vitamins. Green tea has polyphenols and may be helpful. And I'm going to mention fish oil on the next slide. This is a controversial area. These are Omega-3 polyunsaturated fatty acids, you don't make them. You have to ingest them. And the major sources would be fish or the immensely popular over-the-counter fish oils. Certainly may have cardiac benefits. Not reviewing that here. They're very widely used by my patients. They may have anti-inflammatory effects. They actually compete with another group of polyunsaturated fatty acids, omega-6, and omega-6 may be pro-inflammatory. And the absorption and metabolism is quite affected by sex and dietary factors. Observational studies suggest cognitive benefit, but I can tell you the controlled trial results are all over the map, positive and negative. So I've not been that enthusiastic about using it, but I'm telling you, most of my patients are taking them anyway. Alcohol, I'll drink to that. Um, there may be direct toxicity to the brain. There may be increased frequency of traumatic brain injuries. No question that heavy drinking, greater than 3 drinks a day, increases dementia. But is light drinking protective? Light drinking is associated with, maybe associated with worsening CSF biomarkers. And a recent meta-analysis, I'm showing you the results in this graph, suggests some benefit of light drinking and, of course, increased risk with heavy drinking. Look at the solid line, not the dotted lines, which are the confidence intervals. The y-axis is the is basically cognitive dysfunction, cognitive function really. So lower numbers are worse. What you can see is teetotalers start at 1, and then if you go down to 20 odd grams per day, which is about a drink a day, the risk goes down and then seems to come up as alcohol intake increases. I think it's a controversial area. I think we're really not sure whether to recommend zero drinks, or 1 drink a day to our patients. So much depends on cultural factors. I'm not sure how much effect we're going to have. Music therapy. I play music as a hobby, so I'm a little bit of an advocate here. It could be listening or participating in music. Cochrane Review suggests modest effects on depression, but pretty substantial effect size. I'm showing you a meta-analysis here. Pretty substantial effect size of improving cognition and may improve quality of life. However, the benefits may be nonspecific and due to social engagement and attention rather than the therapy itself. You can see benefit in some studies, sometimes for listening, sometimes for actually making your own music. So I think music is good, but we've yet to figure out the ideal way to use it. The main thing in randomized controlled trials are multi-domain interventions. Makes sense just to throw everything in the kitchen sink in there rather than try to study one at a time, simply because these studies are really challenging, really large, and usually need to be long, like 1 to 3 years. They usually combine exercise, diet, some kind of meditation or mindfulness technique, and sleep interventions as you can. There are a number of null trials, though. Finger was the first notably positive trial, 1,200 participants in Finland, followed by 1.5 years. Finland, that's what's called Finger. Um, and the primary outcome was a composite neurocognitive battery. And what you can see on the right, the intervention group is in red and the control group in blue. And these are z-scores, which means you standardize everything to one. One is a full standard deviation. The good news is you saw statistically significant effects on the total score, on executive function, processing speed, not on memory, actually. And it's associated with what they estimated was a 6% reduction in dementia risk. You must know, though, adherence affected the outcomes a lot. This was an intensive intervention, including training at the gym 3 times a week, 1 or 2 group sessions a week to talk about diet and other lifestyle factors, whole bunch of stuff. Um, and a more trial more recently reported, Pointer, also by the amazing Laura Baker, was a similar design, just a kind of a bigger, better, bigger, more robust study. And they compared a structured intervention where they basically worked with people directly, either on Zoom or in person, to encourage them to increase physical and cognitive activity, diet, social engagement, and monitoring cardiovascular risk factors like blood pressure, versus self-guided, where they had 16 meetings over how long is this? 2 years. and the primary outcome was global cognitive functioning. Good news, the structured group did better, statistically significant better. Um, the bad news, it's not a huge effect size. 0.029 standard deviations. It's not a lot or a little. Can't be a lot. But all of this suggests to me that coming to people late in life and making multi-domain interventions gives you a suggestion of improvement, but that my bet is that we have to start a lot earlier in life. There's a number of other trials going on around the world. It's called Worldwide Finger, and these are just a picture of it's on most of the continents of the inhabited in the world, and most of these have ongoing trials. Uh, they've been working hard to figure out what's the best intervention. We may need to target more domains. We may need to combine with medication and supplements. We probably need precision medicine approaches. We probably need to focus on those domains where people might have the biggest shortcomings in their lifestyle or where they seem to be able to make the most improvement. And a caveat about effect size. So this is one of the graphs I showed you before. And the thing that worries me about Pointer, this is a composite cognitive outcome. And over two, we're comparing the structured versus the self-guided group. So over 2 years, the structured group did better with a small but significant effect size. What troubles me, though, is that everybody improved. Dr. Rosenberg, why are you bothered that everybody improved? Well, I'm worried that this is a learning effect, that a lot of it could be from repeating our cognitive tests several times. We we they put every protection in place to not do that, but it's still there's a possibility that we may have been simply training people better in our tests. Conclusions and bottom line. There's lots of epidemiologic and some controlled trials evidence for protective effective lifestyle strategies. The ones I focused on: exercise, diet, depression, brain training, socialization, and hearing. Doing those because I think people can understand them, and I think we can actually, sort of in a real world, make interventions. The caveats are the effect size may be limited. Our trials may be too short. We may need to start them early in life. It's really a bit of a paradox. We can't go and do a 20-year controlled trial, but there may be ways through epidemiology to approximate that. For those of you within Hopkins using the EPIC system, I have a smart phrase that essentially sums up this lecture at a phraseology level suitable for patients and families. Thank you very much, and I will finish my talk now. Appreciate your time and attention.